This video is to demonstrate the advanced cardiovascular exam. So we're going to start with a general inspection of the patient so we can get his overall general health status as well as do an assessment of his hydration. So I'm going to start by standing in front of the patient. All right. So first, again, I'm doing a general inspection, looking for evidence of patient discomfort, evidence of increased work of breathing. And so far, I don't see any of that. I'm going to then move in a little bit closer so that I can do an inspection of his mucous membranes as well as his mouth, looking for evidence of cyanosis. So start by just generally looking at his lips, looking for that coloration. If I saw blue discoloration, that would be the evidence of cyanosis that I'm looking for, which I don't see. I now want to do a quick assessment of his hydration status. I'm going to ask you if you could just take your hands for me and pull down your lower lip so that I can look at the texture of the mucous membranes. Thank you very much. They should be moist, and that would give me, again, an assessment of his overall hydration. So we're now going to move down into looking at his extremities so I can look for other evidence of peripheral cyanosis. So I'm going to take a look at your hands, looking at the nail beds, looking for evidence of cyanosis, which again, I don't see. If this was someone who was wearing nail polish, the option would be to have you flip your hands over for me so that I can look at the pads of the fingers. And again, that's a good pink coloration, showing good perfusion and no evidence of peripheral cyanosis. I'm going to have you flip your hand back over for me, and I'm going to be checking the nail beds for capillary refill. I'm going to press and hold for about 3 seconds, and then release and count how quickly it takes for the bed to refill. It should be less than 2 seconds. All right. And that basically completes our general inspection of the patient. So the remainder of this exam is going to be done with the patient lying down at about a 30-degree angle. So I'm going to raise the bed and then I'll have you lie back. All right, I'm going to have you lie down for me, and then I'm going to pull out the leg rest to make sure that the legs are supported. All right, I want to have a look at your neck. So we're going to be looking at the neck vessels to start with. So I'm going to have you turn your head over to your left side so I can look at the right side of your neck. And I'm going to ask you if you wouldn't mind pulling down the neck of your gown a little bit so I have a complete view of your neck. Perfect, thank you. So for this first part, I'm doing a general inspection of the pulsations on the side of his neck, looking to see if I can actually view and visualize those jugular venous pulsations. Afterwards, I'll need to go ahead and then measure the pulsations specifically. So now we want to take a closer look at those jugular venous pulsations. The first thing that we want to do is take a note of the landmarks. The first landmark we have are the two heads of the sternocleidomastoid. The first one here is the sternal head, which is going to connect down to the manubrium sterni. And then finally, we have the clavicular head, again, moving towards the clavicle. In the V between those two is where you'll find the internal jugular vein. It's deeper and sometimes more difficult to see. So sometimes it's easier to see the external jugular vein, which is going to be lateral to that clavicular head. Because it's more superficial, though it can be less accurate from a pulsation standpoint because it has a more tortuous course. In some cases, I can see those pulsations rather easily in ambient lighting, but sometimes I can't. And so then using a pen light or the otoscope as a light source, I can create some tangential lighting to help emphasize the pulsation. And so now the pulsation becomes easier to see as a result of the shadows that it creates. And I'm seeing his pulsation up to about this location. All right. So now what I want to do is actually measure the height of that pulsation. So how I do that is I want to know the height of it vertically above the sternal angle. The sternal angle, again, as a reminder, is that angle where the manubrium meets the body of the sternum. So I'm going to take a ruler and hold it perpendicular to the sternal angle. I'm going to take something like a swab or other kind of device that I'm going to hold perpendicular to that ruler to the height of where I'm seeing that pulsation. So in this case, we can see that his pulsation is actually really below the level of that sternal angle. So whatever measurement that we get, we add 5 centimeters to that because the heart is approximately 5 centimeters below that location. So in his case, his jugular venous pulsation or pressure would be approximately 5 centimeters of water, which would be normal. So once I finish my inspection for jugular venous pulsations and distension, I also want to be assessing for the carotid pulsations. The carotid pulsation is going to occur up in this location, anterior to the sternocleidomastoid generally. I'm going to ask you to turn your head so that you're facing upwards. When his head was to the side, I couldn't see any evidence of unusual pulsations. So now what I'm going to do is palpate the carotid pulse. And remember, we want to do that palpation individually, not both at the same time. So I'm going to start again using my 2 fingers and palpating up near the angle of the mandible on both his right and then on the other side, his left. And I've got equal pulses bilaterally. So finally, what I need to do for that is actually auscultate using the diaphragm of my stethoscope for bruits in the carotids. So what I'm going to do is I'm going to place my stethoscope on the location where I felt the pulsation, and then I'm going to ask, I'm creating too much tension. I'm going to ask the patient to take a breath and hold it for a couple of heartbeats. So you take a breath for me and hold it. All right, and breathe. And I'm going to do the same thing on the other side. Take a breath for a second. And breathe. The reason for doing that is what we're listening for are bruits that would be impossible to hear over the sound of his normal breathing. So one last thing that we need to assess for is for the hepatojugular reflex. I'm going to have you turn your head back over to the side again for me. So someone with a congested liver, if I press on their liver, what I can frequently see is the raising of those jugular venous pulsations as a result of pushing the blood up out of the liver. So I'm going to lower your gown. Actually, have you lower your gown. And while looking at his jugular venous pulsations, I'm going to press firmly and upwards on his liver. And if he had evidence of hepatic congestion, I would expect to see strengthening of those pulsations, which we don't really see in this case. So we're going to have you relax. And you can go ahead and raise your gown back up again. So at this point, we're going to move forward into doing the inspection of the thoracic wall. So I'm going to ask you to go ahead and lower your gown for me down to about the top of your abdomen. All right, thank you. So I'm going to start with a general inspection of his chest. I'm looking for any evidence of pulsations, any lifts or heaves associated with that. In addition, I'm looking for any abnormalities of the structure and shape of the chest wall. Is his chest wall sunken in, or is it more protuberant out? And again, no evidence of any of those. The next thing I need to do is palpate each one of the 4 valvular areas, assessing for evidence of thrills. In order to do that, I have to be putting my hands in the correct location for those valvular areas. So I need to use the landmarks to find them. So the first landmark that we're going to use is the sternal angle. So that's where I take my hand and run it down the length of the sternum where I feel the change in the direction of it, which is right about here. That is your second intercostal space. And so if I move my hand over to his right, I'm now at the right second intercostal space. And I can place my hands here feeling for a thrill at that location. This being your aortic valve location. If I move now from that same location over to the patient's left, same spot, second left intercostal space, I'm now palpating at the pulmonic area. I want to count down 2 more rib spaces so that I'm now down to the 4th intercostal space, or the 5th, depending on the individual. And now I'm palpating at the location of the tricuspid valve. I want to move down 1 more intercostal space so that I'm at the 5th intercostal space, and then move out to the midclavicular line. Again, that midclavicular line being halfway between the clavicle's insertion in the sternum and out to where it is on the shoulder. And this would be the location of the mitral valve area. This is also the location where we're most likely to find our PMI, or our point of maximal impression. If I can feel that with the patient lying flat, then that's sufficient. But in a lot of patients, you won't necessarily be able to feel it in that location. So what I want to do is have the patient roll over onto their left side, or what we call the left lateral decubitus position, and see if I can feel the pulsation at that location. So what I'm going to ask you to do with my hand resting on your chest, I'm going to ask you to roll over onto your left side. Okay, I can now feel the pulsation against my hand, and I have you roll back flat, and I can take note of where I felt that. If it's in that midclavicular line, then it's a non-displaced PMI. If I had to move my hand more laterally, then it was a laterally displaced PMI. Now that I've done all of that palpation for thrills, and in this case I didn't feel any, I want to auscultate on those same locations for those different valvular areas. I'm going to start by auscultating each of the 4 valves using the diaphragm of my stethoscope. Now, I always make sure that my diaphragm of my stethoscope is actually activated when I start, and it is. So I'm going to start at that right second intercostal space and listen for several heartbeats. At this location, I should be auscultating for, can I hear a normal S1, first heart sound, and S2, second heart sound? Do I hear any extra heart sounds, like an S3 or an S4? And finally, am I hearing any murmurs? So now I'm going to move to the left second intercostal space. My, again, 4th intercostal space on the left. And finally, at the location where I felt the PMI, or the 5th intercostal space at the midclavicular line. Now I want to do all those valve locations again using the bell of my stethoscope. Certain heart sounds, certain murmurs, some of the extra heart sounds like S3 and S4 are better heard with the bell. So I'm going to do the same thing in those same locations with the bell. So again, right second intercostal space, left second intercostal space, 4th left intercostal space, and finally at the level of the PMI. Now at this point, I don't hear any abnormal sounds. But if our patient were to have a murmur, or I had a high suspicion that there could be one there, and I need to attempt to emphasize those murmurs, then we move into our special maneuvers. And the first special maneuver is going to be for that mitral valve area. And it's going to be having the patient move to that left decubitus position while I'm listening with the bell of my stethoscope. All right. So again, I'm going to place my stethoscope in that same location, and I'm going to ask you to roll over onto your left side while I'm doing that. All right, and I'm going to have you roll back flat again. And I didn't hear any abnormal sounds. So for the next part of the exam, we're going to be focusing on the abdomen. So the first thing I'm going to do is let's put your gown back on and cover your chest. And then what I'll end up doing is raising the gown to look at the abdomen. But first, we actually have to do this part of the assessment with the patient lying flat. So as long as your patient is comfortable doing so, we're going to lay him the rest of the way down. So I'm just going to take this, if you just lift up just a little bit for me so we don't drop you, and then lie you down flat. All right, so now what I'm going to ask you to do, if you could raise your gown for me just up to about the edge of your rib cage. Perfect, thank you. So at this point, what I'm going to be doing is inspection of the abdomen. And for the purposes of the cardiovascular exam, what I'm looking for here is for pulsations. And if we look closely in this area, in someone who is thin, I should be able to see the aortic pulsation directly. And in this case, I can actually see his aortic pulsation. So now what I want to do is actually palpate the aortic pulsation. So the aorta should be just slightly to the left of the midline. So I'm going to start with my hands to that just slight left and palpate for the aortic pulsation. All right. In a normal adult, that pulsation should be no more than 3 centimeters wide. So I want to now place one hand on either side of that midline, again palpating for that pulsation. If I can feel it at this location, I should then consider widening my hands to see if that pulsation is wider than the 3 centimeters. If it's bigger than 3 centimeters, then I should have a concern for an abdominal aortic aneurysm. So now what we need to do is auscultate those, taking a step. Before I auscultate, I want to make sure that I also assess for hepatic enlargement. So a patient with congestive heart failure could have an engorgement of the liver with blood and therefore have enlargement. We want to make sure we're palpating for the size of the liver at that particular point. So what I'm going to do is place my hands underneath his rib cage and press upward. If you could take a deep breath for me and let it out. And seeing if I can feel that liver edge and where I can feel that liver edge. I don't feel a liver edge significantly on him, so he doesn't have evidence of hepatic enlargement. Now we're going to move forward with the auscultation of those blood vessels. So there are 3 different blood vessels I'm going to be listening for: the aorta, the renal arteries, and the iliac arteries. So for the aorta, I'm going to be in the midline up in that epigastrium. And you want to listen for the time window of several heartbeats to make sure whether you've heard a bruit or not. For the renal vessels, I want to move just to the lateral of the midline on both the left and on the right. And finally, for the iliac vessels, we're going to move down just below the umbilicus, and again, just to the right and just to the left of the midline. And in a patient, the normal finding would be to hear nothing, which was the case here. So that first special maneuver was for the assessment of mitral stenosis, and it was specifically done with the bell of the stethoscope. The remainder of these are going to be done with the diaphragm. So now what I'm going to do is have you sit up for me. Oh, thank you very much. All right. So this one here is going to be looking for aortic regurgitation. And what I'm going to do is switch over to the diaphragm, because that's what I'll be using for the rest. I'm going to place my stethoscope on the left lateral chest wall next to the sternum. What I'm going to have you do when I tell you to go is I'm going to have you lean forward, exhale completely, and then hold your breath out, okay? And then I'm going to listen for a few heartbeats, okay? All right. So if you could just lean for me and exhale out. All right, you can sit back up and breathe again. So I was listening for if that caused an enhancement of the murmur. And again, I did not hear any abnormal sound. So at this point, I need to listen in the same area, only with you standing and then squatting down and back up again. So I'm going to ask you to stand up for a second, and I'll take your gown. Thank you. So what I'm going to do is, again, listen in that same location, and then we're both going to squat down to the floor and stand back up again. Mm-hmm. All right? Are you ready? Mm-hmm. All right, let's go. And stand back up. All right. All right. Thank you very much. Mm-hmm. So the next part for these maneuvers, I have to have you sit back down and lay down again. Mm-hmm. So you want to go ahead and lie back. And here is your gown back for you. All right. All right. So now at this point, what I need to do is I'm going to ask you to do something we call a Valsalva maneuver. And essentially what a Valsalva is a forced exhalation against a closed glottis. Most of your patients will not understand that instruction if that's what you give to them. So you have to be more clear as to what it is that you're looking for. So 2 different instructions can be used. The first one is asking someone to bear down, like they're going to have a bowel movement. Or you can have them push their abdomen out strongly against my hand and try and push my hand away with their abdomen. Either one of those will lead to that increased pressure that we're looking for. And you're going to do that while, again, listening in that same location with the diaphragm. All right. So I'm going to place my hand on your belly, and I want you to push out hard with your belly. And relax. And you wanted to be listening both during the force part, the grip part, and during the relax. We're going to do the same thing again, only this time I'm going to have you gripping your hands very hard, all right? So what I'm going to have you do is just squeeze your hands together really hard, and then when I ask you to, release, all right? Go ahead and squeeze. And release. All right. Thank you very much. So at this point, I want to point out the fact that we've been doing this all on a male patient. If we have a female patient, under most circumstances, we're not going to ask that person to remove their bra. They are going to keep that on. But that's going to cover the areas that we need to be able to auscultate. So how we work around that is have our patient help us. So when I'm listening to the left fourth intercostal space, just ask her herself to move that bra over to the side for you so that you can listen there. When it's time to listen to the mitral area, what you ask her to do is hold both her bra and her left breast up a little bit for you so that you can place your hand there when you're doing the palpation, or your stethoscope there when you're doing the auscultation. So for this portion of the exam, we're going to be moving on to the assessment of the vasculature of the extremities. So first, I'm going to be doing sort of a general inspection of his lower extremities. Again, looking for evidence of visual swelling, looking for evidence of abnormal dilated veins, such as varicose veins. And so far, I don't see any of those. So now I'm going to move on to the assessment of the pulses. And so I'm going to move back up to assess the femoral pulse. Now, in general, we want to be looking to see if pulses are symmetrical. So in most locations, we want to be able to palpate those pulses at the same time so we can see if the pulse is happening with the same quality and the same timing. However, several of the pulses, that's really not practical. And the first one where that's the case is the femoral pulse. So the femoral pulse we'll be doing one side at a time. So the femoral pulse is going to be located relatively low on the patient. So it's just inferior to the inguinal ligament, and it's about halfway between the pubic symphysis and the anterior superior iliac spine. But we generally don't remove all the patient's clothing in order to do that assessment. So I'm going to ask the patient to lower the waistband of his pants to just below the level of his hips so that I could get to that location. So if you wouldn't mind lowering that for me. And so now, on the edge of his waistband, I can now palpate for the femoral pulse, which I was able to easily find here. If for some reason the pulsation is difficult to find, either related to body habitus or the strength of the pulse, you can always ask the patient to find the pulse for you, and then they can guide your hand to that location to help preserve the patient's modesty. All right, and you can raise your pants back up. I would do the same thing on the opposite side. I'm going to now move down into the popliteal pulse, which is the next one that's just impractical to attempt to do both at the same time because it does require both hands to do it. So I'm going to ask you to bend your leg a little bit for me, and I'm going to rest your heel here. So we need the knee bent, but we don't want him holding his leg up. We want the muscles relaxed. I'm going to take both hands and put them deep underneath the popliteal fossa. I'm going to have them meet in the center, and then I'm going to press deeply underneath that popliteal fossa, searching for the pulse. It is a very deep pulse, and which makes it feel more diffuse. So it is one of the more difficult ones to find. And you can relax your leg for me. And I'm going to do the same thing on the other side. Lift up his leg and have him rest his his heel. And then I'm going to palpate deeply underneath the popliteal fossa for that pulsation. All right. I'm going to have you straighten your leg now for me. So now what I'm going to look for are the pulses in his feet. While I'm here, I'm also going to be checking for the perfusion in his feet and checking for the general warmth of them. We joke that most people have cold feet, but they shouldn't be like ice cubes. They should actually have some warmth to them if they've got good perfusion. And in this case, he does. So I'm going to start with the posterior tibial pulses. And these can be both palpated at the same time, so I can check for symmetry. So I'm going to go just posterior to the medial malleoli on both sides. All right. And I can assess that he has pulsations equally bilaterally. Now I'm going to move on to the dorsalis pedis pulses. That's best found just lateral to the extensor tendon of the great toe. So I can place my fingers here. And then the same location on the other foot to allow me to assess for the quality and the equalness of those pulses. And they are, again, equal bilaterally. So now while I'm here assessing the pulses in the lower extremity, what I'm going to be doing is assessing for edema. You want to start at the lower part of the foot, press for at least 2 seconds, and check to see if I have any evidence of pitting when I do that. If I find pitting edema, I want to move upward on the leg until I find the height of that edema, because that gets me at its severity. Visually at this point, he doesn't have any swelling, but I'm going to start by pressing against a bony prominence in his foot for at least 2 seconds and then release and assess to see if I've left a dent. And in this case, I haven't. If I did find that swelling there, I would move up to the bony prominences of the ankle and then of the shin on the front of the leg, again, assessing for that pitting of the edema, which again, he doesn't have any in this case. To assess for my upper extremity pulses, those are more easily done with the patient sitting up. So I'm actually going to ask you to sit on up for me. All right. So now I'm going to be assessing for the bilateral upper extremity pulses. The first one I'm going to assess for is that brachial pulse. The brachial pulse is just medial to the flexor tendon for the biceps. I can palpate it there. And I'm going to do the same thing on this opposite side. And he has equal pulses bilaterally there. And then finally, for the peripheral pulses, we're going to check for radial, just at the base of the thumb on each side. And he has good, strong, equal pulses bilaterally. That will be the typical end of a general assessment of the pulses. However, if we need to be able to assess the patency of the perfusion to his hand, we can do something called the Allen's test. The Allen's test allows me to assess independently the radial artery and the ulnar artery patency. So I'm going to ask you to relax your hand and just leave it open. I've already assessed that he's got a solid radial pulse on this side, but now what I also need to find is the ulnar pulse, which would be again at the base of the pinky side of the hand. Once I've found that, what I want to do is I'm going to compress both vessels to basically occlude blood flow into his hand. And I'm going to have him squeeze his hand tightly while I'm doing that to help drive all the blood flow out, to cause blanching of the entire hand. All right. So I'm going to ask you to do is grip your hand really tight, and I'm going to press firmly on both pulses. And I want you to release your hand for me. And you can see that it's blanched. I'm going to release the ulnar while keeping compression on the radial, and you can see that his hand became pink again. So that means he's got patency in his ulnar artery. So now I want to do the same thing, only assess for patency of the radial artery. So we're going to do that same thing again. I'm going to press hard. I want you to squeeze your hand for me. All right. And release. So again, he's blanched, and now I'm going to release the radial. And again, his hand turns pink. So he's got patency in both the radial and the ulnar artery, and he's got good collateral circulation between the two. And then I can do that same thing on the opposite hand to test the perfusion in his left hand.